case of a 75-year-old right-hand dominant gentleman with end-stage arthritis of the right shoulder. You can see here that we've already placed his CT plan into our Blueprint software. We're going to first look at the acquired retroversion. This is a case of about 25 degrees of acquired retroversion, fairly significant. We can also look at our program to determine how much posterior subluxation there is of the humeral head. Here it looks like a bit more, but actually when you view it in 3 dimensions, he measures at about 77 degrees of posterior humeral subluxation. The thing I like about this part of the program is that it'll actually show you how much subluxation there is by color coding green, which is posterior to the glenoid center line, and blue, which is anterior. So you can see here that the majority of his head is posterior. So once I'm satisfied with these measures, we have about 25 degrees of acquired retroversion with 4 degrees of superior inclination. We'll go ahead and accept these. One of the things I like about the 3D portion of this program is that you can really get a sense of exactly the glenoid deformity that this patient has. Now he has a little bit more of an atypical posterior retroverted glenoid without really much of a paleoglenoid. But you can see here, as Athwal has described, he has the majority of his wear which tends to be posterior and inferior on the glenoid, which is where most of the acquired retroversion tends to happen. And you can't always get a sense of that on standard 2D CT imaging. So I think being able to toggle this 3-dimensional CT really gives you a sense for where the majority of this patient is having his deformity. The fact that he probably has somewhat of an anterior ossified labrum, and the majority of his wear tends to be posteriorly and inferiorly. So we'll go ahead and accept these CT scan measures. And one of the features of this program that I like the most is the ability to determine whether or not you think a posterior augmented component is going to be necessary. And the computer program will really give you a sense of how much bone you're going to have to take on the glenoid based on the implant that you choose. Here you can see on the Perform pegged Cortilock glenoid, which I happen to like because of the immediate fixation you get with the centered Cortilock hole. And we know that roughly we can accept about 10 degrees of retroversion of our glenoid component. So if we dial in 10 degrees of retroversion, and we dial in quite a bit of superior inclination, you can see that we're still going to have quite a bit of overhang of the native glenoid. So even if I rotate the glenoid component and we medialize it a bit, you'll notice that here on the bottom right of the screen, it'll tell me that I really have quite a bit of problems with the glenoid seating. So if I was to do preferential anterior reaming, we would have to ream quite a bit of anterior glenoid and maybe even increase my retroversion a bit more than I would be comfortable doing. And as I'm scanning on the left, you could see from the axial cuts, just to have the glenoid be seated posteriorly, we'd have to ream into all of this subchondral bone anteriorly. So I think that this case, if we're going to really try to correct our acquired retroversion, using an augmented glenoid is probably one of the best and safest ways to minimize any violation of the subchondral plate. So even though the inclination seems to be spot on, you could see here that as we're reaming into the glenoid, to be able to seat this glenoid where we want it to, we're going to have to violate at least 50%, probably more, of the subchondral plate to get upwards of 80% or more of seating, which is something that I typically try to achieve is 80% or more. So as we shift to a Perform Plus component, you'll notice that there's an increased augmentation posteriorly as opposed to some of the other components and implants that are out there on the market. This is an angled posterior component as opposed to a stepped component or a fully angled glenoid component. You'll see that this has the native backside radius of curvature of a normal glenoid, and then it angles posteriorly. So this component actually comes in degrees of 15, 25, and 35 degrees of posterior retroversion for the posterior augment. So let's start with 15, and we can even use the opportunity of this software to play around a little bit. So if we start at 0 millimeters of depth at 15 degrees and 6 degrees of inclination, we'll see 86% seating, but at this point you can see that we're still a bit retroverted. We're at 13 degrees of retroversion. So usually 10 degrees is the upper limit of normal that I would accept when I'm doing a glenoid implant. So I'm going to scan up and down and see, is 10 degrees of retroversion adequate with 77% seating? How can I get that number to 85 or above? So I medialize the implant a little bit, and you can see here that as I scan up and down on the axial cuts, we're still taking quite a bit of the subchondral plate of the anterior glenoid. Now with this component, we have the ability to actually rotate it. And typically I'll tend to rotate it posteriorly because, as Athwal and colleagues have discovered, most of the bone loss tends to be posteriorly and inferiorly. So as we rotate the implant posteriorly, which you have the opportunity of doing on this program, you'll get more coverage from that posterior augment, preferentially posteriorly and inferiorly. And as I do that, you'll notice that the seating increases fairly substantially to 94%. I'm still a bit medialized, so if I want to play with the lateralization, I'm now at a 15-degree augmentation. I still have 81% seating. But if I look carefully, I do think that I'm still a bit in violation of this subchondral plate anteriorly, not just the osteophyte anteriorly, which we see here. So I'm going to go ahead and play around with the implant augment a bit more and change it to 25 degrees. You can see that that automatically jumped me up to 99% seating, but my implant's a little bit medialized, so what I'm going to go ahead and do is lateralize that. just enough that I feel like it's maybe seated right on that subchondral plate. So you can change the medial and lateral depth of the implant. Here we're at 0.5 millimeters of depth, we have 93% seating, and as I scan up and down, we're pretty much sitting right on the bone. One thing you'll notice is that this anterior osteophyte, which I think is mainly osteophyte or ossified labrum, is going to get reamed pretty aggressively, which I think is adequate because it's not necessarily a huge supporting structure for this glenoid implant itself. So now that I changed that implant augment to 25 degrees, I do think that there's quite a bit more seating posteriorly on the native glenoid with really not too much aggressive reaming of the subchondral plate. You can see that implant sitting quite nicely here. So at this point, one of the things I will notice is that there is some overhang of the implant anteriorly and posteriorly, and if I want to, particularly for a difficult exposure like a posterior retroverted glenoid, you can downsize the implant one size, and that'll still get you nice coverage over the native glenoid itself, and that will help with exposure purposes. We have 97% seating, and we're really not violating much of the subchondral plate. You can see as you medialize it, it'll obviously come to 100%, but as you medialize the implant more, it will take more subchondral bone. So even with 1 millimeter from full depth, we still have 80% seating without violation of the subchondral plate. So at this point, I'm pretty satisfied with where this implant is sitting. I'll make sure that all of my pegs are within the glenoid vault. You can see this one is probably a little bit getting ready to penetrate the glenoid vault itself, so if you wanted to change the position, you can change that from an anterior-posterior perspective, so you can move the implant slightly anterior, and then as we scan up and down, we're still nicely contained within the glenoid vault with 99% seating. So at this point, I'm going to go ahead and save and generate a guide. So typically when I like to generate my guide, I think about very carefully where my retractors are going to be going, and this is very surgeon dependent. When I use a Fukuda retractor posteriorly and inferiorly, I know that one of the rungs of the Fukuda tends to sit right posteriorly and inferiorly on the glenoid. So I've learned, unfortunately the hard way, that this posterior peg tends to need to sit right underneath the scapular spine. So as I generate the guide, what I'm going to do is I'm going to right click and I'm going to pick 3 points anteriorly. I tend to try to spread these out and put them just on the glenoid face so that the guide is not going to rock too much. So I'm going to make sure that I'm just on the glenoid, and then I'm going to put one at the mid portion to give them adequate spread, and then one inferiorly where I know access will not be an issue. And then posteriorly, I think that's the hardest one to choose. Again, depending upon the retractors you use, you kind of have to pick this carefully, so I tend to go right underneath the scapular spine where I know there's going to be plenty of room for this guide to sit, even if I have a leverage retractor posteriorly and inferiorly onto the glenoid. And once I choose my points, I'm going to generate the guide, and then at this point it's going to allow me to place my center pin with excellent accuracy so that I can place my glenoid component exactly as I had planned it. You can see right here, that's where it's going to be. My implant's going to be well contained within the glenoid vault, and I'm going to have plenty of exposure to be able to put this implant guide in anteriorly with one small peg posteriorly.